find people having an absolute disagreement with this bill, saying this bill is bad. I have a very serious problem when very high-profile people go around talking about death panels and euthanasia for older people. To think for an instant that I or any member of the House Republican or Democrat would do that and make people decide or have death panels for euthanasia for people is shameful. All it does is currently what doctors do now. With a patient that has a terminal illness or end of life or seniors, it gives the patient and the doctor and the family the ability to talk about living wills, do not resuscitate, hospice, whether it's home hospice or hospital hospice, different things that are out there, and let the family decide and the patient decide what is best for them. Same thing when my dad was dying and he did not want to have a bunch of medical procedures, and the doctor came out and said, you know, what do you want us to do? And we had a conversation, my sisters and I, and my mother was too upset to attend the meeting, but it just gives the doctor the opportunity to be reimbursed for doing his job, which is to sit down and talk to families about what's available for them. So I want to dispel that right away. Here's the bill in a nutshell, and I'll try to go fairly quickly. If you have insurance now, and you like the insurance that you have, you can keep the insurance. Nothing happens to you. Nothing. The government doesn't come in and take you off your policy and say, here, you must go into this plan. You keep it if you want it. You have two other options as a person who currently has insurance, and I'll talk about people who don't have insurance. If you have insurance and you don't like the insurance that you have, you can go into what's called the exchange. The exchange will be a group of insurance companies that will basically go form policies similar to what I do. I as a member, and I think you should have the same rights I do, and I as you, you go into an exchange, you can shop for insurance policy through the exchange, but in the exchange, these insurance companies have to agree to the following. One, there will be no more pre-existing conditions allowed ever. People will not be thrown off of a policy or not be allowed to purchase insurance because they have a disease like diabetes or have had, cancer in their or heart problems, things of that nature. If a person, and then they also have to say if they say they're going to pay the claim, they have to pay the claim. And they cannot cancel you if you have a claim and you file the claim. They can't cancel you. If you go into the exchange and you don't find a policy that you like in the exchange, again, you don't have to do anything. You don't have to take any of those. There's something called a public option. The public option is basically very similar to, and it hasn't been put together yet because we haven't passed the bill. It will be very similar to what's called like a Blue Cross Blue Shield standard plan. Now, here's where it affects people who have lost their jobs or people who can't afford insurance. The premium for that will be based on 5% of that person's income. So let's say you lose your job and you're on unemployment compensation. Instead of having to purchase COBRA, which is very expensive, as you mentioned, and with a very high deductible, you can go, if you want to, again optionally, into the public option for 5% of your unemployment or your income. You can stay with that policy as long as you want to if you find another job, but when your income goes up, your premium goes up. There will be two or three different plans in there, similar to what you can do in the exchange. You can get a basic plan, you can get a plan that pays more and has more coverage and things of that nature. But the bottom line is it gives people the opportunity to not have to do COBRA. It gives them an opportunity to be able to have health insurance that they can count on being there. We're also going to close the Medicare Part D donut hole for seniors permanently. Had people come into my office, a woman came into my office and thought her prescription was going to be $30 when she went to the pharmacy and found out it was $300. And she began to cry. The people behind her actually collected enough money to get her a third. What's happening, particularly with older Americans, is they will take a portion of what they're supposed to take prescription-wise because they simply can't afford it, or they won't take it at all. And what happens is they become sicker, And I think that's a tragedy. I think that is shameful. And I think, candidly, that bill that was passed before I got there was one of the worst bills that Congress ever came up with. I think that bill was nothing more, in my opinion, than a giveaway to the pharmaceutical company. So what we're asking the pharmaceutical industry to do is to put $12 billion into this bill to close the donut hole, so that if you have a prescription and you're a senior and you go in and you think it's $31, it'll be $31, whatever it is. Now, we're going to cut the paperwork back by about for physicians and healthcare providers, which I think that might come as a blessing for the healthcare providers. It's interesting, you know, we all have our internal revenue forms we fill out. We put different information on them, but basically the forms are the same. They're not different for any of us. If it's 1040, it's a 1040. An itemized deduction sheet is an itemized deduction sheet. It's the information that you put on there that's different. My doctor says he spends just himself 16 hours a week on paperwork. If we can reduce the paperwork, and most people have said, if two things happen. Number one, it gives the doctor and the nurse and the healthcare providers more time to spend with the patient. And you save a lot of money by having standardized forms. And it makes it easier, I believe, for healthcare providers. The other thing with Medicare that we're trying to do is streamline. Now, the scare tactic is they're going to cut your Medicare benefits. That's not true. That's not true at all. If anything, we're going to be able to expand it by trimming some of the things that Medicare does that we think is excessive. For example, why is it that if a person after consultation with their doctor needs a wheelchair and is going to need it for an extended period of time or maybe permanently, why does the person have to rent it, but then an option to buy? Why can't they buy the wheelchair right out? Why is it that the government will pay 4, 5, 10 times more for a diabetic testing device that you can get at the local pharmacy here? We can cut that by making them do what they ought to do, and that's go out and shop to try to get the best possible deal for the consumer.